going. So you've got some folks at the NAMI Our Place Center, and then we've got a few people here, and Margalie is going to join us. We've got Abbey Ferenzi here to talk about GuideLink. She's a licensed mental health counselor, has been working in community mental health for almost 20 years. Well, that's a long time. She became the executive director of GuideLink Center in November 2020, and GuideLink opened in February of 2021. So she's going to share her screen.
Yeah, I just wanted, if it's okay, I was just going to give just a little more background just to explain. I know when I'm listening to people, I kind of like to know where they came from and what they've done. So I started out, I'm actually from Southeast Iowa. I started out at Southeast Iowa case management out of Iowa Wesleyan College, and then went on and got my master's and have worked at community mental health centers ever since then. I worked about 8 years in the Chicago area with housing development programs, housing opportunities for people with AIDS and mental illness, children's and adult programs, crisis services, and a lot of outpatient work as well. But it's all been community-based. I don't have any experience on the inpatient level, but have accompanied plenty of people to inpatient services. And then the last several years, I've been the director of the Abbey Community Mental Health Center and the director, mind you, Kathy Johnson is the VP, but of the center in Cedar Rapids, those community-based services like the ACT team, supported community living, some of our Club 520 peer run services, and then also at the same time oversaw the Iowa City programming. So when this opportunity came along for GuideLink Center, it was right up my alley. For years, obviously I really like the work I do, and that's why I'm still here. But I always have the individuals and families in mind that for whatever reason, even with our scope of services, we could not help because of the constraints of our system that I know we all probably understand. And an opportunity like this to kind of break down silos, bridge some gaps, and hopefully help more people and their family members in some of their most vulnerable times in their lives is really important to me. So I'm really happy to be here, and thank you so much for inviting me today. And I will pull up my PowerPoint now. I'm going to go over a little bit of history of GuideLink Center, some current programming and statistics. I will look for questions throughout. Maybe I can just answer brief questions throughout, if that's all right with all of you. And then I will try to save a good 15, 20 minutes, because typically people have questions for me, so I want to save time.
My audio.
Oh. Are you having trouble hearing me? I'm going to try to share this now. There we go. Can everybody see that? Okay, and just one more disclaimer here. I am on a remote connection at the center. That's a whole nother story with all the different companies we have working here. So it doesn't allow me to see your faces while I'm presenting. So if somebody has a question, would you just say question and then I'll hear you say that, okay? Or if someone wants to alert me, I don't want to miss out on any questions. So GuideLink Center opened last February. We actually just celebrated our first birthday yesterday. Had some cake, talked about all the things we've accomplished, but all the things we continue to want to accomplish. So happy birthday, GuideLink Center. So I thought I'd start off with what is an access center. Access center means, according to Iowa Administrative Code, means the coordinated provision of the intake assessment, screening for multi-occurring conditions, care coordination, and then blending both crisis stabilization services and substance use disorder services, not necessarily on the same site, that's not required, but it is required that there's a coordinated system of care in order to be designated an access center. Here at GuideLink Center, or I'm going to go over that on the next slide, sorry, we do operate under one roof, and I'm going to talk about that more. So what does this mean? And again, I do some presentations with local churches, law enforcement, the hospital. And so again, you might know some of this information, but I just want to recap. The combining and coordinating of services is so helpful because we have people who, are experiencing both substance use and mental health symptoms or effects at the same time, and being able to treat them more holistically often leads to better outcomes. I think all of us know this, but actually seeing it happening here, it's pretty neat to see, because you can see truly when you treat someone as a whole human being and try to address as many needs as you possibly can, especially when they're in crisis, and then link them to ongoing services in the community, we're seeing some neat stuff happening. So part of an access center too is to enhance the crisis care continuum. Again, my guess is that you might be aware that we have some work to do in our crisis care continuum. Lots of good things happening, but again, still lots of work to do. Another reason for an access center is to give the community another option. About, what would it be, 20 years ago, urgent care centers started popping up for medical treatment for individuals who didn't really need to go to the ER, but they needed treatment sooner than 2 days, 2 weeks, or 2 months, which is sometimes, or 6 months, which is sometimes how long people can wait. So those urgent care centers fit that need, but we didn't have anything like that necessarily for mental health or substance use services that could be provided on that urgent care level. So that's, if you want to think of kind of a mindset for GuideLink Center, it's providing that urgent care level. We certainly cannot do everything that an inpatient unit or an ER can do, but I'd like to think we're a lot better than having to wait weeks or months to get in to see somebody. We provide that immediate access to care, which is so important, because when someone's in that moment of crisis or their family's in that moment of crisis, that's one of the toughest times to make decisions and navigate a complicated system. So the idea behind GuideLink Center is to provide that immediate access and ease of care. We're open 24/7. You can walk through the door. Again, we can't do everything here. We will try to do as much as we can. And whatever we can't do, we're going to at least try to guide and link that person, hence the name, to whatever services they may need. It also provides a jail and ER alternative to law enforcement. We are not a locked facility, and we do not do psychiatric holds here necessarily. But I will say, after operating a year, when people come and learn that we are not locked, sometimes they feel more comfortable with staying. Not saying that we don't need secure facilities in our system, and mental health treatment, hospitals, we definitely need secure areas, but that's not what GuideLink Center is. It fits the continuum all the way from what we've seen of someone just walking through the door saying, I don't know where to start, I don't feel good, meaning they're having mental health symptoms, or sometimes they're using too many substances. We get that, or someone's kind of on the lower end of a crisis, they just need to know where to start, all the way up to someone being suicidal, having extreme disturbing thoughts or symptoms to where they need to get in and see somebody right away.
Question, Abby.
Yes.
Does that mean you have like 23-hour observation, that, that clinical definition of it? That's great.
Yeah, that's actually our only service we don't have open yet, is 23-hour crisis observation. But I can explain as we go through this. You're going to see why we're open 24/7 even without that. I'm really hoping in the next 60 days we can have that last core service up and going.
Great.
Thanks.
Thank you.
Sure. So just a little more background here. I can briefly go over this. About in 2010, community service agencies began meeting to improve coordination of systems of care here in Johnson County. So I listed all of these names. Let's see, where's Mary on here? There she is. A lot of people at the table talking about what was needed, what our community needed, and brainstorming, researching ideas for what we could do to provide more access for people in crisis. Here's some more names for you. And then along on the right-hand side there, you can see several agencies or entities that also contributed to some of the ideas and input in regards to forming GuideLink Center. So in 2016, momentum started picking up. Elected officials, law enforcement, a bunch of people took a trip down to San Antonio to learn about the restoration center they have there. It's much larger, much more comprehensive, but kind of serves as the Mecca ideal access center. And they have really figured a lot out. We've actually met with San Antonio several times since then, especially regarding our sobering unit, which is the first in the state here in Iowa, to kind of learn from them and from their model. So there was ongoing government agency and planning. They instituted crisis intervention training for all of law enforcement. And then in 2018, Governor Reynolds cites access centers in her State of the State address. So I don't even know, maybe Mary can speak to this, that they were really calling it an access center when they were talking about it, but this was Governor Reynolds' idea of having what she called an access center in the state of Iowa, and required Iowa to have a minimum of 6. So in 2018, a project manager was hired. There was a lot of area municipalities that donated to a capital project to build this beautiful building after that land purchase. And then in 2020, Dr. Jindal, our medical director, and myself were hired. So as I mentioned, there are now, we started off with 2 oh, hang on, I'm so sorry here. I'm so sorry. There we go. Okay. We started off with 2 access centers when I was starting last year. In Johnson County here, we opened up in February, and I believe Lynn County opened up in May, I think. And then throughout the state, there have been more access centers popping up, and you have to be designated by your region to be considered an access center. And now there are a total of 7. You'll notice up here on the northwest corner, looks like they're hurting a bit for an access center. I have heard, and in fact, some of those counties have reached out as they are trying to form access centers. GuideLink Center here, I host a monthly Iowa Access Center meeting. And luckily we have some good representation from some state folks on there. Laura Larkin with DHS. We recently had the 2 new DHS consultants that have been hired to work with regions to help to oversee the funding, I guess you want to say, or consult on the funding for mental health services in regions. So we're really happy to have that representation, along with some managed care organization reputation. So if we have questions about difficulties with getting reimbursement, which is, to be honest, always an issue, we can actually ask some of those questions on those meetings. And then besides all that, one of the reasons I wanted to start these is I'm all about collaboration. That's kind of my theme here, and supporting each other, learning from each other. And, you know, obviously I'm invested in our GuideLink Center here and in Eastern Iowa, but even across the state and quite honestly across the country, I'm really happy to see these services grow and blossom, and that it really helps when we have a network like this to support each other. Okay. Next slide here, local access centers. So I mentioned GuideLink Center, obviously us. We work closely and partner with the Lynn County Mental Health Access Center. We actually have a lot of clients in common, or sometimes if our beds are at capacity, we might send someone there, or they might send someone here. We actually are the only 2 in the state that combine the multiple companies and services under one roof. So the other access centers across the state, typically they stem out of a mental health center, kind of like Abbey Mental Health Center, and then their SUD services oftentimes are not on site, or they're not located, or they might be very close, but they're not under the same roof. So just to give you a little picture of that there.
Excuse me, what are SUD services?
Sorry, substance use disorder.
Oh, thank you. Okay.
Yeah, I interchangeably say SUD and substance use. Sorry. It's termed different ways and different things I work on. So good question though. Thank you. I think with any of this stuff, we start throwing those acronyms around, and I appreciate being reminded that I need to explain those sometimes. So here at GuideLink Center, we offer core services. So we're designated as an access center. But the folks here in Johnson County wanted to have us have some plus as well, which is a really good thing. That's one of the reasons I'm really happy to be working here. They hired Abbey Health, who is my employer. We are the managing entity. And just to explain to everybody, Abbey Health is different from Abbey Community Mental Health. They are affiliates, but actually Abbey Health oversees several affiliates, including Abbey Community Mental Health. So Abbey Health oversees all the services in the building, but each company has their own employees in the building. So Abbey Community Mental Health Center, which recently merged with Penn Center Incorporated. So now they're, as a whole, they're Abbey Mental Health Center. Prelude Behavioral Services is in the building. Community Crisis Services and Food Bank, and then Johnson County Ambulance. These services still, these companies still have all of their existing services in the community. They just they provided additional staff here for services and treatment that we want here. Excuse me. So we didn't take away, and in fact, that's one of the ideas with partnering with companies already in the community. We don't want to compete. We don't want to take away. And quite honestly, we don't need to reinvent the wheel. These folks already know what they're doing. So to have them come together and work with us under one roof, I think was a great plan, although it's been a lot of work, as you can imagine. So what that has meant for us, and I know certainly this has been my approach and mission, is combining the best parts of the medical world, community-based models, and other models that we want to utilize in combination here, not one or the other. And then getting that frequent external input from advisory boards, community meetings, phone calls that I get, continually getting that. Quality improvement around here is an everyday thing. We're just always trying to get better to create this innovative care model. Some of the additional strategies and approaches we use are the fact that Dr. Jindal, our medical director, and Dr. Gentil Archer, ARMP, are both board certified in psychiatry and primary care. So besides merging the substance use disorder and mental illness service worlds, we also want to add that primary care piece in there, because research has shown, and this has certainly been my experience, the majority of individuals we're serving have co-occurring medical conditions too, sometimes exacerbated by their mental health, or sometimes it's the other way around. And that piece of that person needs treatment too. So that's another strategy and approach that we're using here. So that was a mouthful. So I'm going to give you a picture, hopefully, to explain it a little bit better. So Johnson County hired Unity Point Abbey Health as the managing entity, along with Shelter House is our partner, but I do not oversee Shelter House services. And then we have Prelude, Johnson County Ambulance, Community, and then I don't have my slide totally updated yet. But as of January 1st, Penn Center and Abbey Mental Health Center are one. And then we use that lease staffing. Dr. Jindal also works at UIHC and has her psychiatry, provides psychiatry services, but also has a primary care clinic she works at in Riverside. And then Dr. Gentil Archer is with the College of Nursing. So she actually teaches there, does some research, but then also provides services here. Both Dr. Jindal and Dr. Gentil Archer provide prescriber or provider services here, essentially psychiatric evaluations and med prescribing. Okay, service providers and descriptions. So community, I'm going to start with them and then give you some updates on some statistics. Community Crisis Services provides an essential, they're just at the heart of what we're doing at GuideLink Center. They provide, so you know the mobile crisis team and what they do in the community. Essentially, they're mobile crisis trained, but they're on site. So anybody that walks in 24/7, the first person they're going to see is one of those crisis counselors. Sometimes we have people call ahead and they certainly answer the phones, or sometimes they just walk in. And I'm sure you can imagine and appreciate the scope of everything they see. So I just cannot say enough about how wonderful these staff are and what they do on a daily basis. They do an intake and a brief screening, but all the while also trying to listen and support and just make somebody feel really comfortable here. They know that that's really important to me, and it's important to community as well. And we want to make sure people feel warm and welcome when they come in the door. We've had people wander in with children because they're looking for children's services, which we don't have. And I've seen those triage counselors sit down with them and explain, we don't have this service, but here's some things in the community that might be helpful. Would you want me to help you make a phone call? The idea that I know administratively I'm trying to promote is don't make anybody feel like they walked into the wrong place. Even if there isn't a service here for them, there's something here for them. And so just try to offer them whatever you can in the moment, even if it ends up meaning that they don't essentially need our services. They do a great job at that. They also decide if someone needs to be admitted on site into a program. And so they have all that admission criteria to balance. Or sometimes people don't need to be admitted. They might receive crisis counseling. They might get referrals and be linked to resources. They spend an average of about 38 minutes with people. So sometimes you can imagine that's an hour and a half, or sometimes it's 20 minutes. It just kind of depends. And because we don't have to bill Medicaid for that, our region supports that. It's lower barrier, which is absolutely what we need in a triage setting. So they also do that suicide assessment and safety planning. And like I said, they decide if someone needs to stay or if they're safe enough to return home. Give you some stats on community services. We just did a report, a comprehensive report from last February to the end of January. I don't have February stats yet because obviously we're still in the month. But they completed 109 screenings in the month of January. That's our highest thus far. You can see when we first opened mid-February, we did 13 in our first couple weeks of opening. March, April tends to be a little bit of a slower month, but you can see it kind of gradually grow throughout last year. And then we shot up from December to January to 109. I anticipate that will just continue to grow. So we are trying to staff as many triage counselors as we can throughout the 24 period. We started off with just one, but especially on that second shift where we get most of our referrals, we need at least 2. And it just gives you some averages. That 25 minutes is throughout the year. The 38 minutes I quoted was from last month. So sorry if I got my figures mixed up. But and again, we're finding that most of those referrals and admits come between 4 and 8 p.m. Interestingly enough, during the week, we are actually less busy on the weekends. We get the majority on Thursday evening. That seems to be when we get the most people coming in. So Abbey Community Mental Health, I'm just kind of going company by company here and trying to give you a picture of what they're doing. Abbey Community Mental Health has those crisis stabilization beds. As I mentioned earlier, we don't have crisis observation open yet on site. We're really close. And then subacute care, we do offer, but it's off-site. We have a link to subacute care in Cedar Rapids. So I'm going to focus here a little bit on crisis stabilization because that's one of the core services that Abbey Community Health is running in the building right now. And the idea is if someone needs more care beyond crisis observation, they could then be admitted to crisis stabilization. But right now, those triage counselors and the mobile crisis teams in the community are deciding who needs to be admitted to crisis stabilization. Those services we have, so we have 16 beds total here. 8 are allotted for crisis stabilization. We currently have 4 open, and that's because of staffing. So when we say we're at capacity, it doesn't mean we have 8 of those beds filled. It means we have 4 because of staffing needs and the national staffing crisis, which I mentioned I've been doing this for 20 years. I've never seen it this bad. It is just so exceptionally hard to hire people right now, but we're still working at it. So we got the 4 beds open, and with those 4 beds, we have had 412 admissions since last February. That program includes a licensed mental health counselor like myself, Leonarda Decker. She will see someone within the first 24 hours they're admitted, oftentimes sooner than that. There's also direct support staff working here, and they are at the heart of all of that work. They're working so hard to help with treatment planning, goal setting, and helping link someone to all of the resources that they need, all while helping someone through coping strategies, and helping them navigate what their needs are throughout that time. And then I'm going to talk about this a little bit later, but we also have peer services here as well. I'm going to talk about that role specifically, but the peer is also checking in with folks from crisis stabilization too. Any questions about that? We're trying to get up to 8 beds. That's our big push right now. We have 4 open.
I have a question.
Sure.
Where is the subacute care offsite offered?
Kingston Hill in Cedar
Mm.
Rapids.
Oh, okay.
Yep. And the mental health center runs that as well. They're just trying to increase the number of beds. But again, that requires nursing staff. You'll hear that theme throughout. That's the hiccup for any of this stuff. You probably know what the last couple of years have meant for nurses, and the need for nurses in hospitals. There's traveling nurses getting paid a lot of money, so it's very hard to compete with that as well. But that's the hiccup for more subacute care, because we want to offer more.
Can you repeat the name of that place? What was it?
Kingston Hill. And if anybody, I give my contact information at the end. If you want anything more specific, I can find you like the program manager's number if you want to talk to anybody.
I was just curious, since we seem to be the mental health system for inpatient care seems to be so clogged up from the ER going forward.
Yep.
With nowhere to put people who don't need an awful lot of
you
care,
are
but they need some.
You are absolutely right. And in talking to access centers across the state who have more subacute care, like 4 beds, 6 beds, we're hearing from them that subacute's designed for 10 days, but I'm sure, again, all aware of people not necessarily having a place to go after those 10 days. They can't get placement after that, and they need it. And I think, what did she say? I know they've had at least 2 individuals who have been in subacute for months on end. And this is coming from the other access centers in the state. And from what I've heard, I don't have specific statistics, but it's typically individuals with both mental illness and intellectual disabilities.
Okay.
And there's not anywhere to place them, so they end up in a subacute bed. And my understanding from the hospital is that happens sometimes there as well.
Thank you.
Sure. Some more about the mental health center. So I mentioned Dr. Monica Jindal and Dr. Gentle Archer. She has her doctorate as well, and they're both, I just have to say, wonderful. We hit the jackpot around here. Wonderful people. So Dr. Jindal splits her time as both the medical director and prescriber. Dr. Gentle Archer is contracted through the Abbey Mental Health Center. They both provide consultation throughout the building, prescribe medications, and complete follow-up appointments. And that they also provide that patient education and consultation. And I have to say too, they really meet people where they're at, whether it's their room, whether it's the courtyard out back here, they're willing to sit down with someone wherever they're most comfortable and complete that assessment. Something that we saw as a need here was additional hours. So we've expanded that ARMP role. Dr. Gentle Archer actually has more hours here now. And we did something a little different just recently in the last couple months. We've had peer services here at GuideLink Center, but the 2 doctors, when it came to care coordination and wanting an individual with lived experience to work with some of the individuals they're working with, we actually created and hired a comprehensive recovery coordinator. And this individual is a peer. So he brings, sometimes he will talk to individuals before they see the doctors or before they do anything else, just kind of bringing his experience, expertise, all of his training to help people feel comfortable and heard. He might sit with them while they talk to the doctors or receive other services. And then the other thing he does is within that 7 days after they leave, he follows up to make sure they get that follow-up care. If they are experiencing any barriers, transportation is one of them, or they're just feeling really hesitant. He talks with them over the phone. He guides them to that next appointment. And he's only really been on the job for about 3 weeks because he had to do training in the beginning. And we're already seeing how that warm handoff and that care coordination, especially in those 7 days following, because we have other services that follow people long-term, like IHH care managers and whatnot. But he really tries to, whatever the doctors and the teams here start, he tries to see it to a good outcome. It's really neat. And the other thing behind that as well is we absolutely appreciative for the peer positions and roles that we've had throughout the Abbey Mental Health Center throughout the years, but wanted to take more of this management coordinator type position and integrate that. That's what we're all about right here with a peer role. And we're seeing some great results from that. So. Okay, some more service providers and descriptions. So Prelude Behavioral Services, they oversee the sobering unit. The sobering unit, as I mentioned, first in the state of Iowa. Many people who call, including law enforcement, are asking for detox, but actually what they really need is sobering. Sobering provides that medically safe environment with that direct access to treatment, because not everybody who's intoxicated is going to withdraw. Detox is for people who are going to withdraw, and they require that medically supervised place that's run by nurses. So what we found is some people show up saying they need detox, but really they need that. They get even more oversight and sobering from those paramedics. And I got a nice picture of one of our paramedics here, and thought I'd give you a visual of the intake room and then the sobering units behind there. We have 4 beds available. And in the last year, we've had, oh, I'm so sorry. That's wrong. It's 165 admissions. I mixed the two up. I apologize. I was trying to get the latest stats here. So we've actually had 165 admissions for sobering and 342 for medically monitored detox. Sobering, someone can have a bit of a higher intox level, even up to 0.40. That was not common in community-based substance use disorder services at all. Typically, nurses and community-based providers were more comfortable with a 0.25. However, after Dr. Gentle worked very closely with Prelude's medical director, and because of the oversight she provides here, and because of many people who are chronic users and will have 0.4 or above, we were able to raise that, trying to have lower barriers to get services. We've even seen people at a 0.45 level, and as long as they're trending downward, the paramedics and Dr. Jindal are comfortable with that. Because the reality is, if we don't take them here, they're going to end up in the ER. And I want to state this clearly. I absolutely understand the need for an emergency room. There's just some people that go to the emergency room that don't really need to go there, or it's not the best fit. And sometimes that's intoxicated people, and they might sit there for a long time versus getting this oversight and care that they're getting here. So medically monitored detox, we have people start out in sobering and then end up in detox, or we have people who just come in the door and they're withdrawing. That's where we have the nurses, and it's longer term. The average stay is 3 days. In sobering, someone might just stay 3 to 6 hours. And I think in detox, they can stay up to 7 days if needed. That admission criteria is a little bit lower. Like I said, they're starting to withdraw, and they now have 6 beds available. They started last June. The only service that started in February was triage and crisis stabilization. Took us a little while. Sobering opened in May, and then detox opened in June. They started off with 4 beds, and now they're up to 6 beds available. The Johnson County Ambulance, the paramedics and EMTs in the building, they oversee people in sobering, but they will provide medical assistance throughout the building. This is something I get kind of excited about, because one of the frustrations for me working community work for so many years was oftentimes we would have to take someone, because a lot of the work that I did was being in people's homes. We would have to take or send someone to the ER because when you don't have that level of a medical professional available, you always have to default to ER. It's just kind of the case in community-based services quite often. But now with these paramedics, they can see people. And in the month of January, we had 51 recorded assessments that the paramedics did throughout the building. So that's people in the lobby, people in crisis stabilization. They can provide that comfort for someone who may be having a panic attack, but thinks they're having a heart attack. What do we have? Headaches, swelling, cuts and bruises. They can help with all of that. And just that, even that reassurance for someone that that level of care is provided them to here has helped with a lot of our ER diversion. So we're really happy to have those folks in the building. Being mindful of the time here. So general admission criteria, this is a lot of information, so I just want to give a quick snapshot. Adults 18 and plus, people have to consent to treatment. And I'm going to talk about this a little bit later. I hope everybody understands why we have to have that in this setting, but we are also very, very aware that some people may need these services, but they don't want them. And unfortunately, that's some people who are brought to us either by family members or police. They absolutely need the services, but we can't quite talk them into staying here or receiving the services. Also, if someone's actively violent or threatening violence, we can't have them stay here. We don't have security. We don't have a secure building, although we do have where you have to like fob to get into the patient area. That area is secure, but obviously we don't have the tools or the training to handle it if someone's being violent. We'll try to de-escalate folks. We've had people throw some things or yell or shout. We try not to just quickly call law enforcement or say, no, we can't take them, but there is a limit to what we can do here. So I just wanna make that clear. And then it has to be someone who doesn't require inpatient. For medical conditions, obviously, if they're having a medical emergency, we have had people brought here who are having a medical emergency, so they need to go to the ER. Or if their symptoms are so acute, for instance, an example, someone came here who had no orientation, couldn't tell us his name, couldn't tell us where he was, couldn't tell us anything. So that also requires an inpatient level of care. Any questions about that? Trying to be mindful of the time here. And I will send this out just so everybody knows. I'm happy to distribute this. This is a floor plan of our building, again, just to give you some more visuals. The winter overflow shelter is connected to our building. Again, I don't oversee those services, but we do have some clients in common. And then you can see the layout. We have 16 beds, total bedrooms. 8 are for medically monitored detox, 8 are for crisis stabilization, and then we have a crisis observation area, and then the sobering unit, which currently we have 4 beds available there. Some of this, keep in mind too, is COVID related, like the sobering unit. We could take more eventually. We haven't had the need for more at this point, but we can't have people. We do require masks here if you're in the common area, but in sobering, obviously, when people are intoxicated, it presents a danger to keep a mask on. So we've got to have a lot of space there.
Can I ask a quick question?
Sure.
What are those areas designated shell? I'm just curious.
Oh, so the genius minds that built this building included shell space. It's just extra space that's not currently being used for whatever else Dr. Jindal and I concoct that we may need down the road. And I shouldn't just say Dr. Jindal and I. Dr. Jindal and I consult a lot, but from community input as well as to what maybe some additional services we could have here that could be helpful. But this first year has been spent just trying to get those core services off the ground. That's the lobby area there. This is a triage room along with that crisis observation area. You can see that there. And if you go to our website, there's actually a virtual tour, just to let you know. There's one of our rooms. The rooms each have their own bathroom and individual temperature control, which is great. Trying to provide comforts to, again, reduce any issues to why someone wouldn't want to receive services. That's our staff area there on the left. So you would have prelude nurses working there. You'd have DSPs. You'd have the counselor in there. Our peer would be in there. You don't see anybody right now, but they are all working in collaboration and in conjunction. Everyone obviously has their own roles, but we often consult with each other, or we might have a client who starts out in medically monitored detox. It's found that this individual actually has some mental health symptoms or conditions as well. And then the doctor or the peer or whoever might recommend, you know what, they really need to see the counselor and they probably would benefit from a few days in crisis stabilization. That's happened quite a bit here. And then on the right here, you'll see that's the area for eating. We do continental breakfast, a hot lunch, and then we have a sack lunch dinner. Okay, so some statistics at this point in time, we've had 1,100 encounters. So that means someone walking through the door and talking to the triage counselor, which has led to 858 admissions. Our referral sources are biggest. We're actually getting the most walk-ins right now. After that, we get referrals from the ER and hospital systems, Mercy, UIHC. And then after that is law enforcement. We've had about 150 admissions for law enforcement when they're bringing someone in. They sometimes bring someone to our Sallyport area if it's sobering. Sometimes that's a jail alternative or a public intox alternative, or they might bring someone through the lobby. And then other referral sources are the mobile crisis team. That's another big one as well. And then we've also had some referrals from jail alternatives. We serve not just Iowa City, Johnson County, but the entire East Central region. And in fact, we will not refuse anyone from anywhere that they're from across the state. So some other outcomes, that comprehensive care, I think I've given some examples about that. I could give you a lot more, but it would take me a lot longer to talk about. But I can assure you that the services that are being completed here are trying to treat a person holistically in the moment, why they're here, and provide whatever that, provide that comprehensive care. Typically we work in our silos of here's substance use care, and here's mental health care, and here's primary care, and we're trying to bring some of that together to treat that person in the moment. Admission criteria, so we do bill insurance for some of our services, crisis stabilization and detox. As I mentioned, triage, we don't bill insurance, and sobering, we don't bill insurance. Whenever you bill insurance, there's admission criteria. I often have to explain that. It's not that we don't want to treat everyone here, but we have to have the resources and we have to have the reimbursement for it, because we'll never have this place fully funded from an external source. We have to be able to bill insurance. However, the culture that I'd like to think we've created here is screen in versus screen out. We're going to try to find reasons that we can help someone versus that we can't help someone. And some of that admission criteria, like I mentioned, for sobering and detox has actually been loosened a bit, so we can find more ways to be able to treat someone here if they need it. Another thing I'm seeing, hear this all the time from the nurses and some of the staff, just being able to see those better outcomes for some of our clients or feel more supported. For instance, like our direct care staff might be working with someone in crisis stabilization that has an underlying substance use issue, and they might talk to one of our detox nurses about that and get some suggestions and offer some help. I mean, you can imagine how that's really helpful and fulfilling to feel like you're doing a really good job. And so I hear that too from the detox nurses. Some of them worked for years in detox, and they're just so excited to be able to see some of their patients get that mental health care that they've needed all along, and they get it on site, or they work with the peer, they get linked to the Abbey Health Center. Because as you can imagine, treating some of those underlying causes of that addiction might prevent relapse. And then some other statistics, we have client satisfaction surveys here. Our satisfaction rate is about at 95%, but trust me, we still try to dig into that 5% as to what's wrong and what can we fix and what can we do better. And we've gotten some good quotes here from clients. There's a lot of them. I don't know, we probably have about 30 so far. I just included a few on here. that make me feel really proud and make our staff feel really proud. We go over these quotes each month with all of staff. But something as simply as one of the quotes on there, the staff at GuideLink are so friendly, that means a lot to me. I want people in general to feel like they're treated as a human being. They're treated like they belong here, and they're treated without judgment. Some of the training and discussions we have here around our culture is, you know, just because somebody needs help, it doesn't mean it's because of some moral failure. The more we treat mental health as brain health, as we talk about, or treat it as we would a physical illness, the more people realize that this is not someone's fault that they need treatment. It is simply something that they need treatment for, and everybody needs to be treated as such. So just a quick snapshot here. I know I'm talking too long here, of the counties that we've served across the state. And then we've had about 24 people that would not disclose. That does not mean they can't be treated here, but we do try to gather demographic information. I also have quite a bit of demographic information, but it would take me too long to go over. But I can give you a quick couple. You know, we serve about half males, half females. It's about an even split here. Same with the age group. It's all across the board, 18 all the way up to 75. No real outliers there. Race though, we do see the majority, I want to say it's 80% Caucasian here. That's pretty reflective of the Iowa City area and Iowa in general. However, we're always working towards, you know, we just got some more flyers distributed in Spanish. We have translation services here. All of our staff are getting trained, safe zone training from the University of Iowa, and we want to be class certified by the end of the year. It's an extensive training. We did a lot of these like 1-hour trainings in the beginning, but it's important to us here to have some ongoing training because, as you can imagine, it takes more than 1 hour to help people not just learn about it, but live it day to day when they're working here. So class certification is cultural and linguistic aware services. And that's through, it's a national project, but the DHS is offering it right now. So we're going to do that. Our diversion statistics, February through December, this comes from the person themselves. Now, eventually we can learn more from the managed care organizations or whoever else, IHH, but right now we are simply asking a person, if not for here, where would you have gone? Or we ask law enforcement, the same thing. So right now, about 53% of people would have went to the emergency room, about 9% would have went to jail, and 38% would have received inadequate care. In the beginning, we were just tracking emergency room versus jail, but that inadequate care piece, I know I'm speaking to the choir here, is exceptionally important as well, because not receiving the care you need could absolutely lead to some poor outcomes that I know none of us want to see. Oh boy, I'm running out of time. So I just want to let everyone know, I'm going to talk about some of the gaps in our current crisis system. GuideLink Center, as I mentioned earlier, does not solve all of the problems in our system. It solves a portion. It's a great start, but we're also tracking here, when can we not accept someone? And as you can see, we narrowed it down to, of all the people we couldn't admit into GuideLink Center, there's a certain portion of them that was their own decision. They either decided not to stay, or they weren't going to follow some of our basic safety rules, like wear a mask, or you can't have you can't use drugs in the common area, those types of things obviously pop up. But there's also a portion on the right side there where we had to say no, and we want to figure out why. Sometimes that's been because we've been at capacity, but that area on the right, those folks who are either medically unstable, have disruptive behaviors or aggression, or psychiatrically unstable, we don't just want to leave it at that. We want to ask why, and what else do we need in the system to treat those individuals as well. So when I do these talks and presentations, and I will talk to anybody who will listen to me, we still talk about all the great things that GuideLink Center can do, but also that data that's showing the gaps that still continue to exist. So we've outlined some of those gaps. When I say we, I mean, Sarah Nelson with Community, Kathy Johnson, Jackie Smith-Duggan, you know, we outlined some of those. And the need for improved services for people with chronic, severe, or complex needs, including those with anosognosia. Again, like I said, we have people who, family members who bring people here, but they need treatment, but they don't want it, or they don't understand that they need it. We also have significant gaps in children's mental health services. I get asked all the time, when are you guys opening a children's access center? I really hope that happens. Absolutely. And we need it. Right now, I know we're focused and licensed for adult, and then prescribers and nurses and DSPs, needing more of those and really needing a good livable wage for our DSPs. I could spend a whole nother 45 minutes talking about that, but we have some of our lowest paid staff members providing consistent supervision and treatment to some of our highest needs folks, whether it's here at GuideLink Center, in habilitation homes across the state. That is just not right. So I really want those professionals to get paid that good living wage, and for people to understand the value of what direct care staff bring to our services. So lastly, this is my last slide, I think here, almost. Okay, we just need to continually collaborate. I do it all the time. I'm trying to do meetings. We set up regular meetings with law enforcement, shelter house, the hospitals, public health is another area. NAMI obviously is on here. And my little slogan, I don't know, I just came up with it. We got to put our heads together to improve brain health care. It takes all of us working together in the community and beyond to solve this problem, that it is a problem and we've got to keep working on it. So again, GuideLink Center is part of the solution, but it's not the whole solution. The last slide here is for communication and updates. I am so happy to receive feedback at any time via email, call, there's my cell. And whether you have an experience yourself with GuideLink Center or know of someone who does, I want to hear about that, because we're running 24/7. We have almost 55 staff working here. You can imagine where someone might not get the memo on something. It happens, we make mistakes, and I want to be able to follow up on that and try to, like I said, quality improvement here. It's a continuous thing. All right, let me see here. There, did I stop? There we go. Okay, sorry, I know that, I try to leave more time, it's so hard. Okay, any more questions?
I have a question. How is your 23-hour services different from what they have at the university hospital?
So actually both of those services are considered crisis observation. The hospital, their crisis stabilization unit, according to code, that's actually a crisis observation unit. So what they have there, where people are sitting in an area having nurses come in and out, that's actually what we will have in crisis observation as well. So we actually follow the same rules.
Is there any way that they're the same or different?
Well,
I guess the more important part is, how are they different?
Yeah, I guess that, so again, we follow the same rules, and that you have to have nursing oversight. Someone has to have that one-on-one, like they don't leave your site in those 23 hours. That's a lot different than crisis stabilization, where someone can go to their own room. I would say the difference here, like I said, I can't say there's a difference in the services because we should both be following code, but I'm hopeful that since we have other services in the building, including those substance use services, or someone might need to transfer to crisis stabilization or subacute, that we could offer that smooth transition right here in the building.
Oh my gosh, having the ability to go to one's own room during that time would just be amazing.
Yeah.
Thank you.
Sure. Thank you. Oh, I see stuff in the chat here too. Okay.
I think we're okay.
Got it. Okay.
One thing we're going to do, Abby, is you and I talked about, is to put together a group to come for a tour.
Yes.
So I'll be contacting you to do that. It is really something to see in action, and I highly recommend it. So I'll put together a tour and work with you on the best timing for that.
That would be so great. And typically Fridays seem to work best, just so you know. We are, like I said, open 24/7. Even doing this presentation, I'm here. I had to put a few signs on my door. There's always stuff happening around here, but we have found, for whatever reason, Friday mornings and early afternoons seem to be the quietest to get a good tour. So.
Okay. Well, great.
Can I
Anyone
ask a
else?
question? Yeah,
Nope.
can I ask a question?
You bet.
I am wondering if somebody walks in the doors of GuideLink Center, how long it would take for them to actually meet with somebody that could provide meds?
Oh, that's a very good question. So our two prescribers, they're called all sorts of different things. Prescriber isn't my favorite term, but that's what they are essentially. Our two doctors here, they are here Monday through Friday, and they're here about 5 hours a day. So typically anybody can be seen to get meds within 24 hours. That's worked out thus far, but we want more prescriber time. That is absolutely a need. We're trying to get nights and weekends. It is also our most expensive service. So you can imagine getting that funded is a little tough because, again, another soapbox for me, our current Medicaid reimbursement rates, what we'll hear from people is, well, you get paid Medicaid for that, it's covered. It doesn't cover the actual costs of nurses and physicians. So we have to continue to advocate, especially from the region, for additional supplemental funding. We're not saying fund the whole thing, but we have to have supplemental funding. Otherwise we can't, no provider in their right mind is going to be able to take that kind of a loss. So hopefully we can get some more, but right now we can see people within 24 hours, or if they come in during the day, like for instance, Dr. Gentle Archer was noticing that more people were coming in on Thursday afternoons. She switched her time to Thursday afternoons to try to catch as many people as she can. So not great, but pretty good.
So I did hear that, I think I read somewhere, did Community get a grant recently, or one of the entities in the system got a grant?
Grant. Well, Community, besides working at GuideLink Center, they're a huge part of the 988 development. So they probably have gotten grants. I mean, they're really going to be adding a lot of staff here in the future. 988 across the state is huge, and they're a big part of it. So that grant might have had to do something with their mobile crisis outreach or whatever other programs they're putting into place for that 988 response.
Great.
And just real quickly, 988 is basically 911, but for mental health, and it's going to be coordinated across the state.
And I think Community last night at the city council meeting, they approved like $1 million in funding for several, I think, crisis counselor positions. I'm not totally familiar, but they got that last week.
Yeah, that's right. And just a good example of, like, I'm aware of what these companies are doing within the building and kind of aware of what they're doing outside, but I didn't know that happened yesterday. So that's good to hear. Is the criteria for admission to crisis bed similar to that of an inpatient? So actually, no. For an inpatient unit, and that's a good, thank you for bringing that up. An inpatient unit will have ligature resistant type area to where you wouldn't even have a TV in the room. I mean, it's someone is suicidal with a plan and intent. Here at GuideLink Center, we absolutely work with people who are suicidal. That might mean ideation, frequent thoughts. They might even have a plan, but no means. Enough to where we determine they're safe enough to be in these rooms or in crisis observation. So someone might have a higher acuity to get admitted to the hospital versus here. My hope, there's a lot of people that go to the hospital right now who might be suicidal but don't need inpatient care. My hope is that in the next 2 to 3 years, we shift the culture, that more people use this urgent care level first, and the people who really do need that inpatient care, there's more room for them, if that makes sense, in the ER where they really need that inpatient secure setting. But right now, and we've been here a year, but we've just scratched the surface of what we can do because people still tend to just think ER and they go there. So we get a lot of referrals back from the ER, but I'm hoping eventually once we get the word out more, which we have a big kind of marketing thing happening here pretty soon. Hopefully you'll hear us on the radio or see us on social media, getting people to understand that you can start out here first. And you know what, just like an urgent care center, if it turns out someone needs to really go to the ER, we'll facilitate that. But you still didn't come to the right place. We're going to help you get there safely. So the majority of the people that we see here, we can serve here.
In my experience with crisis systems, it takes a long time for a community to figure it out.
Yeah, yeah.
But you're there, right?
Yep. So we're just gonna keep talking about it, and you'll see us maybe sometimes in the newspaper, or I've even gotten on TV a few times just to help people understand, including our law enforcement, our paramedics. I work a lot with first responders for years. It's like, okay, suicidal, ER, when really actually we can work with a lot of people who are suicidal here, just not with the means, intent, plan, that if all those pieces are there, they really need to be inpatient. But there's a lot of people on various ends of that spectrum. So.
Yep. And that just need a safety plan and someone to.
And they need a safe place for a while, and they need to talk to counselors, but don't necessarily. It's funny when I have hospitals come through here, they'll see the rooms. They're like, oh my gosh, you have TVs in these, there's a cord back or something. And we're like, well, remember, that's not our level of care. Now we have people who maybe they might increase their suicidality risk while they're here. So we might keep their door open. We might do 10-minute checks. But a few times it has popped up here where someone actually had a plan, like I'm going to walk out into traffic, and we're like, okay, we got to get them to the ER. So that's what we do.
Well, thank you, everyone. You have any more questions? I think we've covered it.
Feel free to share this. I'll send it to you. Okay.
Great. Thank you.
Thank you so much, everyone, for listening.